Hello, everyone. Good afternoon, and thank you for joining us for our Safety and Health Battling COVID-19 webinar, Working Safe Amid the COVID-19 Pandemic. I would like to thank everyone with UT Health, School of Public Health, Health and Safety Council for being with us today. The attendees and our viewers, you are in for a treat. We have 6 distinguished doctors available to talk to you about COVID-19 and how you can protect your workplace, your employees and customers. So thank you so much to all of the doctors that are with us today. Today, we'll discuss creating a safe, healthy, and functional work environment, protecting your employees, clients, and customers from COVID-19. The following information will be shared with you today: where we stand with COVID-19 and the whole situation, the correct use of the terminology, the methods to reduce risk in the workplace, a review of resources available to you and your employees. And of course, at the end of the session, we'll have our question and answer session with the panel of health and safety experts. With us today, we have Dr. DeLocos, we have Dr. Dofrate, Dr. Emery, Dr. Christina Mena, and might I add, we have a special announcement. She's celebrating her birthday today, so very happy birthday, Dr. Mena. We hope you have a great rest of your afternoon, and thank you for taking the time to be with us today on your special day. And Dr. Rios. We have our moderator, Dr. Heisler. He's the Chief Medical Officer and Vice President of Health Operations, Health and Safety Council. And I just wanted to share with you a little bit more about Dr. Heisler. He graduated from Louisiana State University with the Bachelor of Arts degree, from the University of Texas with the Master in Public Health, and Ross University with the Doctorate of Medicine. Dr. Heisler completed his residency in occupational medicine at the University of Texas, training at companies such as Shell, Chevron, and ExxonMobil. He is certified as a medical review officer and has a lot of other distinguished credentials. He's often asked to be a speaker at regional and national conferences, and he will be our moderator for today. So with no further ado, I'll turn it over to Dr. Heisler so he can carry on the discussion with all of our esteemed guests. Thank you so much for being with us today. Dr. Heisler?
Thank you, Mary Ellen. I appreciate it. I didn't know I was going to get the full bio. I appreciate that. Thank you very much. Let's see here. If I can share this screen, we'll just tack on from where we left off there. So again, thank you for having all of us today. We've done several webinars over the course of this pandemic on various topics. So I think we're going to kind of combine some of those today and chat a little bit about what's going on. We fully realize that sometimes having your city on the local news is a good thing, but obviously in the case of El Paso, we understand what you guys are going through, and that you've had a lot of hardship over the past couple of weeks and months. So we want you to know that we're thinking about you, and hopefully today we can share some of our insight and help guide you on your path forward. And hopefully we'll all have a vaccine pretty soon and we'll have this pandemic behind us. So without further ado, I think, George, are you up first to talk about this chart?
Yes, I am.
All right, take it away, George.
Okay, thank you, Tommy. So I just want to cover a basic review of where we stand with respect to COVID. It's not a good time to be in a pandemic, as I think everybody knows. Right now, worldwide, there are over 63 million cases and close to 1.5 million deaths. In the United States, we are approaching, well, we've just passed 13 million. And at the rate that we're going, the time that it takes to tack on another million cases has been rapidly increasing, to the point that we would add about 1 million. In the last couple of weeks, we added it within less than 10 days. In the US, we are over 260,000 deaths and approaching 300,000. And next slide. However, when we give average numbers, which is what average or total numbers, that doesn't tell the whole story. So it's important to understand that at any given point in time, there's a lot of variation across the United States in terms of hotspots, of activity, areas where things are actually relatively quiet, and then those that are very, very hot, for example. And that's what this map, which is from yesterday, shows. The current hotspots in the US are the darker colors, colors. And you see that in Texas, West Texas, it's very dark. But I don't know if the slide shows that the El Paso County is actually a shade slightly lighter. So things have, number-wise, have gotten a little bit better within the seriousness of the situation in El Paso over about the last week. But do keep this variability across the country, with some areas with more cases and other areas with fewer cases, in mind, because one of the things that I've learned after these 9 or so months of the pandemic is that if you happen to live in a low prevalence area for disease, you shouldn't really just stick your chest out and boast, because in a couple of weeks you might be on the dark side and one of the darker areas, and it's gone back and forth ever since the beginning of the pandemic. Next slide, please. When we, Dr. Mena was kind enough to share these statistics from El Paso yesterday, and it's important to understand when we look at this, that this simply provides a little bit of a snapshot in time. And you have to look at what's going on in El Paso compared to where we were a week ago, 2 weeks ago, 3 weeks ago, et cetera. So as of yesterday, there had been, I'm not going to read all of the numbers, but the important numbers, the total number of new cases was 461. That's in one day. And the positivity rate was over the weekly, the 7-day average positivity rate was 13.59%. This is a number that you'll often see quoted on TV, because it gives us an idea of how rampant the infection is in a given area. And generally, things are considered to be headed under good control when they are below 5%. You see that yesterday, the positivity rate in El Paso was around 13.5%, but 2 weeks ago, it was 23%. So we're not where we want to be yet in El Paso, but at least this week, and I emphasize this week because with the holidays and everything that's coming on, I wouldn't say that we've established a trend yesterday. I mean, just based on yesterday's data, but at least it's better than 2 weeks ago. Total number of deaths is 924, and there's a large number of patients hospitalized in the ICU and or on a ventilator in El Paso. But a few weeks ago, the situation, I believe, was more dire, with hospitals overflowing to the point that they had to be transported to other areas. Next slide. So this is a graph that also illustrates at the level of the state, Texas, the same thing that I was trying to illustrate with the map of the United States. There is a lot of variation across Texas. In Texas, we have the largest number of cumulative total of cases of COVID of any state in the United States, well over 1.2 or 1.3 million. And over the last few weeks, things had been getting worse. But you notice in this map that there's a lot of heterogeneity. It looks like patchwork, right? The bluer areas are areas that within the past week have improved their numbers. That doesn't mean that they're, where we want them to be, but they are improved with respect to the previous week. And the darker, more orange and beige areas are areas that are getting worse. And if we look at El Paso County for this last week, again, it's blue. And so things, the numbers are a little bit lower than they had been in the previous week. Next slide. Okay, the devil's in the details also with respect to other things. And the next several slides are related mainly to Texas overall, since I know we have, even though this is focusing largely on the El Paso area, we do have an audience that is even broader than El Paso. This is prepared by our biostatistics department here at the University of Texas Health Science Center, Houston, or UT Health as we like to call it, that is tracking what cases have been doing in Texas since the very beginning of the pandemic, since we started tracking this, which was at the beginning of March. And superimposed on this curve, this is the number of daily cases, and the line is the 7-day moving average of daily cases. Superimposed on this line are the different actions that were taken or things that happened along the way. So for example, and it seems like it was hundreds of years ago, but toward the end of March, cases started to increase. And notice that they're barely above the okay line, or the zero, excuse me, not okay, the less than 1,000 line. They started to increase, and it worried people enough that shelter-in-place orders were implemented in different parts of the state. And they worked. The increase stopped and it leveled out to the point that at the beginning of May, the governor ordered some limited reopening of facilities. And for the next couple of weeks, and you always have to wait a couple of weeks after you make a change, because that's how long it takes for cases to appear as a result of whatever it is that you did, either appear or hopefully disappear. And you see that the first couple of weeks after the phase 1 opening, the line stayed pretty flat. Things looked pretty good. But beginning towards the end of May, around Memorial Day, and especially beginning of June, with subsequent loosening of restrictions by the state, things started to change, and they changed dramatically. And so beginning in June, but well into July, and the middle of July came the big surge of the summer, right? With increases in cases to the point that the governor at around mid-July put the brakes on the reopening and actually took some steps back. And that had an effect that we see the numbers went back down, so that September and October, even though we never got back to where we were in March, things got considerably better, and we're doing okay. And then beginning towards October, again, with more loosening of restrictions and school starting, and in some areas at least, we start to see an increase again, and we are part of the national increase. So this is by far the biggest of the peaks we've had so far. And it can be due to a number of reasons. Yes, relaxation of some restrictions and more reopenings, but also other factors. Colder weather in some parts of the states forced people to spend more time indoors than outdoors. Outdoors, the risk of infection is less than indoors, and not everybody has spacious indoor settings in which to congregate, and so the opportunities for close and large and close gatherings increases, and then we superimpose the holiday season, right? So Thanksgiving, I think the jury is still out as to what this last long weekend will mean in terms of change in the rate of cases. We won't know that for another week to 2 weeks, but certainly it occurred in the middle of a marked increase in cases. And if in fact cases do increase further as a consequence of Thanksgiving holiday, we have around the corner the rest of the month of December with all of its holidays as well. And so this reflects, to a great extent, a lowering of our guard, with fewer folks abiding by things like masking, social distancing, good hand washing, avoiding large gatherings, and it takes a toll. Next slide, please. A couple of indicators that you may have heard on TV or in gatherings about COVID is what's called the RT estimate. Some people call it the R naught value. The R naught value is a number that tells us how many people a single person that has contracted COVID, how many other people will that person spread it to on average. And if you take the SARS-CoV-2 virus, which is the virus that's responsible for COVID-19, which is the name for the infection, on average, if you don't do anything, if you don't restrict anything, you don't wear masks, you just let the virus be in its natural state without any type of protective measures, the SARS-CoV-2 virus has an R naught value of around 2.3 to 2.5. That means that each infected person on average will infect another 2.3, 2.5 persons. The flu is much lower than that. The flu is around only 1 point something. And measles, which is a disease that we now have under good control, has an RT value, an R naught value of around 15 to 18. So there are viruses that are much more contagious than SARS-CoV-2, but SARS-CoV-2 is very contagious as well, and certainly more contagious than the flu. However, once you start implementing different measures, masking, social distancing, hand washing, limitation of gatherings, you can take that R0 value and reduce it. And that's the goal that we seek. And the goal is ultimately to get it below 1, because if you reduce the R0 to less than 1, that means with all of these measures, an infected person on average will infect fewer than one other person, which is good. And so if you look at October and November, I mean, we definitely reduced it with all of the measures that began to be implemented in April and May, with some spurts in June and July, which is when we had the first big surge. It went up again above 1. Then it went down below 1 in August and September. And then in October, it started creeping up again. And so until about a week ago in Texas, our R0 value was still above 1. But in this past week, it's gone below 1. That's good. However, I think we need to be very, very cautious, because this only reflects the past week. And in the past week, with the Thanksgiving holiday, there was a lot less testing going on. Places that normally open up and do tests were not doing it. People were not getting tested. And so we need to be careful before assuming that we're headed on the right track, because it may be, in fact, artifactual due to less testing going on. Next slide. We do look, one of the things that that you may surmise from what I just said is, if I said less testing going on, the positivity rate goes down. Well, it might go down or it might not, okay? So one of the things that has been said sometimes is, well, the cases are increasing all over the United States because we're doing a lot more testing. And there's no question that if you test more, you're going to find more, and not all of that necessarily needs to be severe disease. However, it doesn't necessarily explain everything, because if all of the testing, all of the increases in cases were due simply to more tests, you would see a parallel line between you'd see two parallel lines in this graph between the number of cases, which is the orange line that's increasing, and the number of tests that are being done. And so you see that when the orange line rises faster than the blue line, that means that the increases in cases are not explained only by more testing. Now if you look at November 11th forward, the lines seem to be parallel again, which is good. Maybe the increases that we're seeing, or that we saw in the period, the week of November 11th through November 18th, were due more to more testing. So you have to keep in mind the relationship between those two things. The next slide. And again, this is data from our biostatistics department here at the University of Texas. They track all of these slides. The last 4 or 5 slides that I've shown you about the state are developed by our biostats department. And if you're interested in accessing, it's a very user-friendly site, and the source is, the website is noted here on the bottom right corner of this slide. But one of the things that our biostatisticians have also been doing is trying to predict, based on what we are seeing in the community, trying to predict which way things could be headed. And there's some good news on this graph. So again, going back to March, we see these were actual numbers. We see the surges in July and August, then it comes back down. And then starting in October, it takes a rapid rise. And in the last week, it seems to have gone down. Now, some of that, again, may be artifactual. But what they do is the line that says November 30th to the right, which is, they try to project into the next week or so. And they project possibly a decrease, a little bit of variation in the case, but a decrease, possibly, but also a potential increase. That gray area that you see on the right simply is the range of estimates, and they can go from getting better to getting worse. And a lot of it is going to depend on what happened during Thanksgiving and what happens from this week on out. Next slide. And I believe my next slide is my last slide here. Yes. So the other thing, to make it more local, and I don't have statistics for the El Paso area, these are from the Texas Medical Center in Houston, but one of the things that you always want to keep an eye on is not only are the cases increasing, but how bad are the cases? How severe are they? How many deaths are they occurring? And how are our hospitals able to handle it? I have to admit that in this latest surge, in Houston, at least in the Texas Medical Center, we have done okay so far. And we track a number of different indicators, both from the community as well as in our own hospitals, to try and keep tabs on how things are going and whether or not we need to make adjustments. So one of the things that we follow is the RT, the value, the R value that I mentioned earlier. And you'll notice that in the last week, it also declined not only in the state, but in the greater Houston area. That's a good thing. In the previous week, it was above 1. So in only 1 week, it's dropped to below 1. But again, that may be artifactual. Number 2, we keep an eye on the positivity rate for our hospitals. It's around 6.9%. So it is higher than it was last week. We are seeing more positives. It's still lower than in the general Houston area, which is close to 9% the last time I checked it, 8.8% a couple of days ago. But we also look at how many of these cases are having to be admitted into our hospitals. And of those that are admitted, how many have landed in the ICU, because they represent the sickest patients and those that are at greatest risk of death. And you can see that if we look at hospital admissions, as of yesterday, we were admitting a little bit less than in the previous week. We were admitting about 159 new patients per day into, and these are several hospitals in the medical center, many, many different hospitals, as compared to 168 the week before. So that was encouraging. Now that's a little bit harder to, to explain by the Thanksgiving holiday, because once somebody is sick, if they're sick enough to go to the hospital, they're going to go to the hospital whether it's Thanksgiving or not in the majority of cases. And then we finally look at our ICU capacity, because as long as your ICU capacity is good and can absorb the number of patients that are admitted to it, the mortality actually stays pretty low. We've learned a lot on how to treat sick patients with COVID. We have standardized protocols. We didn't in the very first months. We were flying by the seat of our pants, but now we know how to treat each type of patient, and the mortality is very low. The exception to that is when the hospital systems are overrun, when their capacity is overrun, because then the standard of care suffers and the likelihood of deaths increases. And it's not enough to just say that you have beds in a hospital. You also have to have the staff to run those beds. So you may have lots of ICU beds. If you don't have nurses to take care of those patients in the ICU because they're out sick with COVID, then you're going to fall into the same situation as if you had no beds. So these various different numbers that I presented to you today, from large, from the bird's eye level of the world, the country, the state, and then getting more granular and looking at specific areas, and then within the health systems. Thank you.
Thanks, George. We do have some great questions coming in, and no matter what platform you're using, if you're on Zoom, you can use the Q&A button on there to type in questions. Some of you have typed them into the chat box. That's fine too. I think some people are on social media, whether or not that's Facebook Live. Feel free to type in a question to whatever platform you are on, and we will be sure to get as many of those answered as we can. And speaking of that, there are some good questions, George, that came in relation to your graph. So I'm going to go back. I think this question was posed last time, and it's a great question. When you look at West Texas, the question was, this is a sparsely populated area. Why is it so dark?
Right. And that is a great question. It's because they color them by county. There are actually other maps, and the New York Times has some maps like this, where they adjust for the density of population. So for example, if you look at Presidio County, there are probably very few people that live there, but the number of cases this week in Presidio, which might be 10, for example, compared to last week, which might have been 5. Now that's not, every case is an unfortunate case, but that's an increase in 50%, for example, but in a sparsely populated area. And yet, because they do it by counties, the entire county gets punished, if you will, by the same shade of orange or whatever. it would be much better to do it in terms of adjusting it for population density.
You're right, and that the question may have actually been about this graph.
Yes.
Same
thing.
Same question, right? West Texas is so dark, but yet it has, sparse population.
That's right.
Excellent, thank you. Another question related to your graph was probably this. Is this a 7-day moving average?
Yeah, the line is, yes.
Okay, so their question was, why do we measure things in 7-day moving averages?
Well, that it used to be in 14 days at the beginning, right? Because the incubation period is 2 to 14 days for the COVID virus. It's simply to look at the window of time where following an event, an intervention, or if you want, an exposure. Okay, so the event could be universal masking, mandatory masking, or the event could be opening up restaurants or bars. You have to allow enough time to go by before you expect cases to either improve or worsen based on what you did. And we know that the incubation period of COVID is 14 days, but in reality, the majority of cases are going to occur between day 5 and day 8 from the moment that you made the change. So that's roughly about a week. So it makes sense to follow weekly moving averages, because to allow enough time for the cases that will appear as a result of whatever it is that happened to see what its effect was.
Excellent. Speaking of the R naught value, the question was, why is this virus more contagious than, say, the flu?
Well, it depends on the viral characteristics, the proteins. You really need to ask a virologist about the why, right? Some of it say that the form of the virus with all of its different spikes makes it easier to latch on to certain parts of the body. And once it latches on, it has more of a chance of penetrating the cells in that area. But I really don't know. As well as if you ask me, the measles virus is probably more contagious, not only because of the characteristics of the virus, but because it is very easily, it's very easily airborne. The SARS virus can also be airborne, but it's usually in circumstances like you're singing, you're shouting, yelling, you're speaking, and then it projects beyond the famous 6-foot distance, right? Most of the COVID spread is still within that 6-foot distance. There are exceptions, but with measles, no. Measles is so contagious. It's once you're in a room, if you've never had measles and you're even at a distance, but in the same room as another person more than 6 feet, the likelihood that you will get measles is almost 100%, because it'll stay in the air a lot longer. It won't fall to the ground.
Interesting. Okay, excellent. We will definitely get to more of the questions, so please feel free to type them in wherever you are, and we're going to answer them along the way and then save a lot of the time at the end to answer all of the questions that we can. All right, Dr. Rios.
Hi, everybody. My name is Janelle Rios, and I'm coming to you from Houston today. Thank you for having us on, because this is a very important topic for El Paso and the surrounding area. So I definitely encourage you to ask all the questions that you can. And to let you know too that this works. And what I'm going to share with you today, this works, and we know that it works. So what I'm going to share with you is a well-known and often used public health tool that serves as the foundation for controlling hazards in the workplace. And it's called the hierarchy of controls. The hierarchy refers to each of the levels on this inverted pyramid. And this is how it's typically shown, as an inverted pyramid that's color-coded. The most effective control methods are at the top, and that's what I'm trying to show in the arrow on the left-hand side, that the most effective control is elimination and the least effective control is personal protective equipment. So first I want to identify the hazard, and that is the virus that causes COVID-19. So now let's go through each of the layers. Thank you. So elimination being the best control is we really want to physically remove or prevent the virus from entering the workplace. And the way to do that is to employ self-screening requirements for your employees so they stay home when they're sick. That's going to involve some training on what symptoms that they need to look out for. Limit the number of people who are coming to the work site. Now, I know there are several retailers that are on the webcast today, and that you can't control, actually you can, but the number of people that are coming to the work site, you may want to spread them out a bit or encourage them to wash their hands so that if they had the virus on their hands, they're not bringing it into the retail establishment. And if you're not a retail establishment, perhaps limiting visitors to the work site to only those that absolutely positively need to be there. And this is the most effective control. Next slide, please. Next is engineering controls. And this means that we want to isolate people from the hazard. Again, the hazard being the virus that causes COVID-19. So wherever you can create some barriers between your worker, your employee, and visitors coming to your work site, that will be very helpful. For example, you see in a lot of stores now, the plexiglass barriers. I just went to Lowe's the other day because one of my Christmas lights, I needed to fix it. And they have really nice plexiglass barriers between the cashiers and the customers that are coming through the line. And what I liked about their plexiglass barriers is that they went up very high to accommodate taller people like Dr. Emery. You can't tell he's sitting, but he's very tall. And these plexiglass barriers are also very wide, which prevents the cashier from peeking around the barrier to talk. Because I have seen in the past that people will take their cloth mask and pull it down and peek over the side of the barrier so that they can be heard better. That really defeats the purpose of these controls that are in place. So please tell your employees not to do that. And it's for their own health. Another engineering control that is fantastic is to use disinfectants. So Tommy, if you go on to the next slide, this is a screen capture from a very helpful government website with the EPA. It shows the list N disinfectants. So these are all of the disinfectants that so far have been shown to disable the virus. So one of the nice things about this particular tool is that it's very searchable by a number of different parameters. And the one that I have shown right here in purple is contact time. Contact time is important because when you use a disinfectant, you want to let it sit wet on the surface that you're disinfecting for a certain number of minutes. And that's called contact time. So the disinfectants are listed in order by contact time, either 1 minute all the way up to 30 minutes. So that's something to pay attention to, is make sure that the chemical is sitting on the surface nice and wet for that, whatever the contact time is for that particular chemical. I will also add here that in this photo, you see that the person using disinfectant is wearing gloves. So keep in mind that these disinfectants, they're strong chemicals. And so it would be good to have your employees wearing gloves and perhaps wearing a respirator that I'll talk about here in a moment. Next slide, please. Continuing with engineering controls, another option is to look at HVAC technologies with air conditioning and heating systems. For example, there are some ultraviolet lights that can be placed within the ductwork that would disinfect the air by shining this ultraviolet light on the air as it's passing through the lamps. This is a capital cost. It's going to be expensive, not only to install the equipment, but also to maintain it, because lamps get dusty and they need to be wiped down every so often. And keep in mind that that's a very dirty atmosphere. and that the worker who's cleaning off those lamps, they would also need to be wearing personal protective equipment. And that those are examples of engineering controls. Next, administrative controls. We are changing how work is performed. So for example, if you work in a workplace where telecommuting is an option, encourage telecommuting. So I'm working from home today, so I limit my time in the office. And when I do go to the office, I tend to go in the evenings when other people aren't around, or on the weekends. If you're using telecommuting technologies like Zoom or WebEx, GoToMeetings, there is some amount of training that has to go in to so that your employees know how to use that technology. And I'm trying to hurry up here. So practicing social distancing, we hear that on the news all the time. Keep your employees apart from each other. So if they all have to go into the office or into the retail establishment or onto the construction work site, keep them 6 feet apart at least. 12 feet would be better, but at a minimum of 6 feet apart. We know this works. We absolutely know that it works. If possible, stagger shifts so that folks aren't in the same room at the same time as much as possible. And limit the amount of sharing of equipment and tools. Perhaps there are some daycare centers on the call today. You want to limit the amount of toys that are being shared from children, and disinfecting those things and letting them dry so that the kids aren't exposed to the chemicals as well. So those are examples of behavioral controls. Personal protective equipment. So here I have, this is an N95 respirator. This is a KN95 respirator. This is an elastomeric air purifying respirator. And the cartridges aren't on there right now, but there would normally be filter cartridges on either side. These things are meant and designed to protect the wearer. So they are individually and professionally fitted onto the face of the wearer. That's critically important, that people understand that a safety professional will come and fit it to your face. And then you're taught how to put it on, how to check the seals, and then how to take it off so that you don't contaminate yourself. So these are meant to protect the wearer. So if we move on to community protective equipment, those are the cloth masks. So this is a homemade cloth mask. It is 2 layers, 2 layers. I have another one that another friend of mine sent me that's manufactured commercially. And I have a face mask that's disposable. So, and this is also 2 layers. This is really designed to protect others from you in case you're an asymptomatic carrier. That way, as you're speaking or singing, or if you're hollering to somebody in a different part of the work site, especially on construction sites, you're protecting others when you're wearing these kinds of things. Wearing these and requiring folks that are entering the job site to wear them is very important. So if there are 3 things you're going to take from my part of the presentation, it's wash your hands, wear a mask, and these disposable or cloth masks are perfect, and then stay 6 feet away from each other. Those are the top 3 things that we can do, and they work, and we know that it works. So thank you very much for your attention.
Thank you, Dr. Rios. Appreciate that. Oh, this is me. Testing options. So I just chat briefly about the available testing options that we have to detect this virus. And, not a lot's changed over the past several months. We still have the tried and true PCR test. That's the gold standard test. It's been the same since it was launched back in, February time. And that's if you pull up through a county health tent and do a drive-by test, most likely that's the test you're going to get. We also have another one called the antigen test. This is the quick test that you can get. It's still a nasal swab, but it gives you results quicker, usually within several minutes to several hours versus many hours, if not days, that the PCR takes to get back. You also have the antibody test, and we're going to chat a little bit about the differences of these. Both the PCR and the antigen test are both nasal swabs, deep nasal swabs, all the way back to what we call the posterior pharynx. So it's not a pleasant test to get. But both of these check for the actual virus in the body. If it detects the virus in the body, it means you've got virus in your body, which means you're infected. If you compare that to the antibody test is a blood test, usually a finger stick test, and that's going to show if your body has recovered from this virus and developed any antibodies to it. Pros and cons to these things, again, the nasal swabs are not a comfortable test to take. They don't hurt, they're just uncomfortable. They burn, it's uncomfortable. You're gonna wanna itch your nose, your eyes water, it's not comfortable. The PCR sometimes can take a day or even more to get back. When we were at the height of this virus in the summer, sometimes it was taking me 10 days to get a PCR test back. Well, by 10 days, it's really irrelevant if you're positive or negative anyway, because by that time you're out of the quarantine. So luckily now the labs have kind of caught up, and I think our turnaround time here in Houston has been within 48 hours for a PCR test. So it's a lot quicker than it used to be. The antigen test, again, is that deep nasal test. It's less sensitive than the PCR test is. The PCR is almost 100% sensitive, whereas the antigen test is around 88% sensitive. So it is still a good test, just less sensitive than that PCR test. Again, the antibody test is to show you if you've had this virus in the past, weeks prior, and now have formed antibodies to that virus. And again, not everybody that had the virus and has recovered is going to produce antibodies, but it's still a good test to help you determine if you've had it in the past and if you have some sort of immunity to that virus. All right, that's all I have about the testing. Who's up next?
I think that's me. Thank
Christy.
you.
All right,
Yes,
take it away.
Thank you. So as this pandemic has continued, there's a lot more that we're learning about the virus. A lot more studies have been done about safeguards and about how to mitigate risks in different settings, including the workplace. And two of those, cross-contamination and frequency of cleaning disinfection, a lot of studies have been done addressing the environmental persistence of SARS-CoV-2 on various services. Some of you may have seen a study that was highlighted on ABC World News Tonight last month. It was published in the peer-reviewed journal Virology, where they looked at the survivability of this virus on different types of services. And they looked at all different types of cloths, including cotton. They looked at glassware, different fomites, which are inanimate surfaces like desktops and keyboards and computer mice. They looked at cell phones. And overall, they found that this virus could survive at room temperature for as long as 28 days on these various surfaces, including, again, surfaces that could be in workplace settings. The investigators, though, do claim that they used higher viral loads in these studies, but they say that it's more representative of what would be released in the environment from a sneeze or a cough as compared to other studies that reported shorter numbers of days, 2-3 days, for example. I think what the take-home message here is that those studies, the recent ones I mentioned, were done under laboratory controlled settings. There was no intervention, no cleaning, and this virus is relatively unstable compared to other viruses that are more commonly found in our environment that we encounter every year. Norovirus, the cruise ship diarrhea virus, rotavirus, the daycare virus, those can survive even cleaning regimens for lengthy periods of time. So this virus is not a hardy virus, but without interventions, these studies are showing that they could be on surfaces. And a recent study published last week in the American Journal of Infection Control showed that there can be hand to desktop or computer mouse transfer. So it's just something to be aware of. And in thinking about what Dr. Rios mentioned with those list in disinfectants by the EPA, And that would be the most effective way to disinfect surfaces, using those and considering contact times, et cetera. But it's also really important to make sure that the surfaces are clean first, because any dirt and debris on those surfaces will negatively impact the efficacy of those cleaners, and also UV light disinfection that I know some businesses use. I also want to mention that if we ever find ourselves in a situation again where disinfectants become scarce, because this virus, due to its structure, is relatively unstable, vigorous scrubbing with soap and water can mechanically break down the virus. So it's just important to frequently clean those surfaces. Another factor that can impact not only community transmission, but workplace transmission is the improper interpretation of testing. So I think it's been mentioned, if you think you've been exposed and you get tested too soon, you may be a false negative. If you decide to get tested because you want to travel later, and you need to remember that test that's taken on a given day is a snapshot in time, and that by the time you get your results that may say negative, you could have been subsequently exposed from your surroundings and infected. Another aspect that's a growing body of literature that I find fascinating is household transmission. And I'm not talking about large gatherings. It's looking around the world at how household transmission from within homes, individuals, can contribute to community transmission. And it looks like it can contribute to community transmission in different ways. It's not clear why. In some places it has a greater impact than in others. But what we're talking about here is that by the time someone in your home realizes they may have been infected, they get tested, they get the results, they're a confirmed case, the chances of them transmitting that virus to at least one household member is highly likely. If that household member is an essential worker or just works outside the home and then is infected and then subsequently exposes others to the virus, that's how community transmission can be impacted. So household transmission is something that is getting a little bit more attention. And again, not just for the large gatherings. And then finally, the client interactions. The best laid plans in a workplace setting for safeguards and exposure mitigation can be thrown out the window when the public enters. Working with clients and patrons can disrupt those safeguards. So it's important to think ahead about what could happen so that potential transfer of the virus can be minimized. And with that, I'll just mention that the El Paso campus of UT Health Houston is working with the city through CARES funds. We're working with many businesses in El Paso to learn from them about their operations, their nuances, how they interact with the public, so that we can work with them and collaborate to devise the best workplace safeguards. So if any of you would like to collaborate and work with us, please reach out, and we look forward to it.
Thank you, Christy. Appreciate that. All right, this is a Dr. Bob Emery slide.
Okay, I think it's just my slide is really to just underscore some of the comments that have been made so far, but I think they're really important points, and to also add in a few other nuggets. So my 4 take-home messages here is, some of you may remember that early on in this whole event, the virus was referred to officially as a novel coronavirus. And unfortunately, the media and others have dropped the term novel, but it is indeed a novel virus. And that's an important aspect, because the term novel is really important. What it means is it's a new virus, and that there are some aspects of this virus that are known, but there are others that are not known. And there's science emerging on a daily basis about this. So for example, early on, epidemiologists were concerned about, can someone transmit this virus without them personally exhibiting symptoms? That's always an issue of concern in these sort of outbreak events. And you may remember that early on, there was a call for not getting masks in the community. And the idea there was that they didn't want to run on limited personal protective equipment that the healthcare providers needed. So these are just examples of how, as the science emerges, more is learned about the virus. And so my comment to you is, you should set the expectation for yourself and for your colleagues, your coworkers, and others, and your loved ones, that things may change as this evolves and more information is known. For example, we'll probably get into it in the question and answer period about using the loose term quarantine. But when someone pops up positive, the length of time recommended for one to sequester themselves has changed. And we're going to see other things change as we go along as well. So just keep that in mind. Also, Dr. Delclos mentioned this R value. Just to be clear, you'll see sometimes in the popular press just an R, or you'll see R sub naught, like an R0, or an R sub T. So R sub naught is the value that says, it's something that we certainly monitor, and that is how many additional cases would you expect from one positive case, and but with no controls in place. So R naught means no controls. And as George mentioned, the R naught was early on was expected to be about 2.3 to 2.5. RT is the transmission with controls in place, all the things that have been discussed, such as hand washing, social distancing, staying at home if you're sick, those sorts of things. And those turn out to be very useful and known to be powerful interventions. And that's where we're getting into an RT value. What we're shooting for is a value below 1. So that's my first point. Second point is we talk a lot about screening, but it really emphasized to all of your sphere of influence that screening actually begins at home. I think that was a point that was brought up in Dr. Rios's presentation, that when I think the public hears screening, they think of either testing or they think of temperature checking or something like that. But I would encourage you to discuss with others that screening actually begins at home. Be aware of the signs and symptoms. And if you think you might be ill or have been exposed, please don't come to the workplace. Please don't go to school. You can follow up with your healthcare provider and find out about testing. But please understand that as Janelle's diagram showed, that elimination piece is really the most powerful. The third point has to do with masking versus personal protective equipment. And this is another area where emerging information is coming out. We've got, for barriers to transmission, face coverings and surgical masks. Those are intended to keep you from inadvertently infecting someone else. And there's been some recent papers that have shown that these dual cloth homemade or purchased masks actually do offer some protection to the wearer as well. I've seen numbers between 30 and 40% effective for protecting the wearer as well. So that's good news that when one wears a face mask out in public, that they're not only protecting others, but they're actually affording some protection to themselves. And then we've got the personal protective equipment, things such as the N95s. That was the big shortage, trying to get those masks that Janelle's actually holding up right now, the N95 mask, and then the P100, or she refers to as the elastomerics. We'll have to get you some filters to put on that so you can have you have them. Okay, yeah. So there's a P100 filter there. Okay, great. And then you're seeing a lot on the news now with the healthcare providers, which are called PAPRs. It's probably the most comfortable of the protective equipment to wear. It's a fully encapsulated hood that has a fan on it, and those are intended to protect the wearer. And I'm sure that the healthcare providers who are afforded a PAPR are very, very happy because they're much more comfortable than the other ones. My last point has to do with cleaning and disinfection and environmental persistence. Again, this is a good example of how numbers are changing. There were early on studies showing that the virus could be viable on stainless steel and plastic surfaces up to 72 hours. Now, Dr. Mina has mentioned a current study that shows the viability could be much longer. So two things we want to look at there. One is the use of EPA registered disinfectants. So want to make sure that when you go back to your place of work, physically go and look at what it is they're using and make sure it's one of those listed in the disinfectants on the EPA website, and check what the contact time is. Because we see it here with our housekeeping staff, where they are going to the high touch surfaces, doorknobs, buttons, that sort of thing, and they spray it and then they wipe it right off. And that's really not doing us any good. We have to actually let the stuff sit for it's approved. Matter of fact, the way that it's approved through the EPA is that they actually spray it on a surface and let it sit for the contact time. So if you're wiping it off too early, you're not really doing much good there. I would also forewarn you that, as Janelle pointed out in that photo, that the folks were wearing gloves when they were using some of these disinfectants. You probably want to read the label and see if they are compatible with certain fabrics. And in other words, it could result in staining or bleaching on certain fabrics. So you might want to check on that as well. Especially, my hunch is the longer the contact time, the more likely it may cause a decoloration to fabrics. But I'm not quite sure on that, but something to consider. I think the next slide is just a series of references that may be of interest to you, and look forward to having a conversation when this is all done and try to answer any questions you have.
Thank you, Dr. Emery. No need to memorize these or take pictures on your phone. This presentation will be available on many different platforms. It is being recorded, so you can go back and reference the entire program if you need to. So these references will be available to you as well as the entire presentation. Okay, Dr. Dave Dufresne.
All right, greetings. This is Dave Dufresne reporting in from the UT Health School of Public Health campus here in San Antonio. And I know many of the participants on our call today are representing so many different employers. And so we've had a number of questions that have been asked regarding, well, what does OSHA have to say about COVID in the workplace? And just a reminder that OSHA is our regulatory agency that wants to make sure that employers are providing a safe workplace. And so they're mainly interested, and they're primarily interested in making sure that the employer is protecting workers potentially from COVID, the spread of COVID in the workplace. And so there are two things that an employer needs to be paying attention to as far as what they need to report to OSHA. And it's what we refer to as recordable and reportables. And so there are several state-based OSHAs out there that have made the news really in the last week, where they've really intensified their enforcement efforts. California being one of those. They just announced a very strict enforcement plan. But here in Texas, we follow federal OSHA guidelines, and they have not come out with any specific enforcement regulations as far as COVID is concerned. So we have to go by what is already on the books. And so we want to pay attention to what they refer to as recordable and reportables. And so if you do have a case, a COVID case of a worker that you have to determine that it is transmitted or they contracted it there in the workplace, then by OSHA guidelines, you do need to record that on your OSHA 300 forms. And OSHA has provided some guidelines, and that is confirmed by a positive test, and it is work related. Now that is a big question. How do you determine work relatedness? How do you determine if a worker did contract COVID while at work? And so OSHA has provided a little bit of guidelines, some input on that. Basically, it's going to come down to your reconnaissance, your investigation. Obviously, if you have a number of cases at work, then that's probably a good indicator that something may be spread around. There may be a situation where COVID is being transmitted in the workplace. And so that's how they determine that. But they also acknowledge that COVID is transmitted in the general public. And so it may be that they bring COVID to work. And so they did not catch it there at work. Also, you need to record a COVID-related as work-related case if they do need medical treatment beyond first aid. If a patient goes in, they get a positive test and they're just told to go home, then that's not necessarily a work-related case because they did not receive medical treatment per se. Obviously, if they did go into the hospital and they were hospitalized, yes, absolutely. It does need to be recorded on your OSHA 300 form. So those are the recordables. The reportables, yes, you do still need to report. Actually pick up your phone and call OSHA to report if, unfortunately, you do have a case of an employer or an employee who contracted COVID and they did succumb to COVID and they died, or if you have a worker that is hospitalized because of COVID and they are work related, you do have to report those to OSHA. The fatality has to be reported within 8 hours, and the hospitalization has to be reported to OSHA within 24 hours. So those are two things, two responsibilities of the employer that I need to pay attention to. I did put a couple of links there that come from the OSHA website. OSHA has provided a number of great resources on there, and those recordables and reportables guidelines are on there as well. And so I'll just direct you to that. And so I think that I'm bringing up the end as usual. And so I guess I'll throw it back to Tommy. And I guess right now we go to questions and answers.
Absolutely. Thank you, Dave. So there are several good questions that are coming through. So again, if whatever site you're on and you're watching us, if you have a chat box, a question and answer box, feel free to type in the question and we will get it all to this panel to see if we can answer some of them or all of them. So let's talk a little bit about the upcoming vaccines. I think the vaccine looks to be pretty effective, the ones that are out there to be reviewed, and we should have them in our hands over the next weeks, if not months. So some good questions on the vaccines. Here's one on risks, and it basically is, what are the risks of taking this vaccine, and how do we encourage our employees to not be afraid to take it? Who wants to jump in on that one?
I can take that one.
Okay.
So thanks. That's certainly the question of the moment, right? The development in such a short period of time of a vaccine that appears so far to be extremely effective, not just effective, extremely effective, is really going to be a game changer here. So the information that we know on safety largely comes from the press, what the manufacturers have told the press. And it seems that overall, the two vaccines so there are many different types of vaccines. I believe last time I counted, there were like close to 200 different vaccines being tested all over the world. Only a few will actually make it to the top. And it's very likely that the two that we're dealing with now are going to be those at the top. Anyway, the issue with the vaccine safety, what we have heard is that and remember, between the two studies, the Moderna vaccine and the Pfizer vaccine, which although they are different companies, it's the same type of new vaccine. It's called an mRNA or messenger RNA vaccine. What we know is that out of the close to 60,000 people that were in the trials, it was tolerated very, very well. There were no serious adverse events. Some people did have reactions like low-grade temperature or pain at the site of the swelling or some muscle aches and fatigue that typically lasted 24 hours or less. And then they went back to the way they were. No serious adverse effects. However, the details on safety are really going to be presented to the U.S. Food and Drug Administration, the FDA, on December 10th. And the FDA will look at a lot more data that has been given to the general public so far and use that information from examining this deep data in a detailed manner. They'll decide whether or not to give it an emergency use authorization, which is the way for it to start being administered to the public. All indications point to the fact that they are going to issue this EUA, this emergency use authorization. I do think that overcoming what is called vaccine hesitancy is important nowadays, because you can have the best vaccine in the world. If people don't want to get it, it's essentially not going to achieve the goal that we want to achieve, which is to get enough of the population protected that the virus just basically drops dramatically. It's what's called herd immunity. But if people don't take it because they're reluctant to it, to do so, well, then you need to address that somehow. And I would encourage you, I would encourage everybody to get the vaccine. It's going to be made available in phases, and sooner or later it will be available to the general public, probably toward the, I'd say between April and June of next year. It will finally be widespread. There will be enough of it to go around. Personally, I would encourage everybody to get the vaccine. I'm going to take it. There is no question. I wanted to look at some of the preliminary data. I've looked at it. I trust the sources of the data. I trust the FDA, and I'm going to get it whenever it's my turn. And I would encourage you to do the same. Now, how can companies do their part to encourage their employees to get vaccinated? Well, give them the information sources, access to the information sources that are out there talking about the vaccine. Make sure that they are reliable sources. I typically go to the FDA or the CDC for my information. And both of these agencies are really now trying, after a bumpy start in March and April, I will admit that, but now they are really going above and beyond and trying to make everything they do transparent. So as an example, the December 10th meeting of the FDA to grant or not grant this emergency use authorization is totally open to the public, nothing hidden. So there are things you can do. You might look at creative ways of engaging those employees and managers who have taken the vaccine to sort of serve as ambassadors to other employees and tell them about their experience and encourage them to use it. There are a number of ways.
Thanks, George. Another question in related to the same topic is, should we be concerned that this vaccine got pushed through with record warp speed time, that they cut corners on the safety precautions?
I think it's an important question. I do not think, I think there was a lot of temptation to rush it through even quicker, but fortunately, this is my opinion, the FDA resisted that temptation. So it makes it seem, the way it's presented makes it seem like this vaccine was, that people started with a blank sheet of paper in February and designed a vaccine and then put it through all of its different paces and, whoopee, now we've got a vaccine. Actually, the work that is behind this vaccine has been going on for more than 20 years. It wasn't specific to the SARS-CoV-2 virus, but it was specific for vaccines. So the technology and the science were there. Typically, any drug, any medication, and a vaccine in this regard is a medication, in order to be authorized in the US, has to go through a series of studies with different phases. We don't have time to go through all of them, but they start with very small groups of people up to what we call the phase 3 trial, when they are tested on tens of thousands of people. And that has been done. So it was done. It was started in August. They enrolled almost 100,000 people in these trials, the two companies, in record time. Then the FDA said, okay, you've enrolled them, you've given them their 2 shots because both vaccines require 2 shots. Now you have to wait until you have at least 2 months of data. So it makes it, and they did that. And both Moderna and the Pfizer are now have applied for this emergency use authorization because they've reached the 2-month mark that was required by the FDA. Now, is 2 months too short or not? Well, actually, 95% of anything, of bad things that can go wrong with a vaccine are going to happen within that window of time. If you ask me, are we sure that there won't be long-term effects after that? I can say no, because we haven't had enough time to follow that. However, long-term effects associated with vaccines nowadays, any vaccine, is extremely unusual and is usually picked up by looking at what happens in those first 2 months. And they have that data.
Thanks, George. I did see over the weekend, the Surgeon General was asked that very same question about safety precautions being skipped over. And he said that none of the usual safety precautions were skipped over. He said what was skipped over to allow this to be, pushed through in warp speed is an application sitting on a government desk for a month, not getting looked at. He said, or having 10 other vaccines in the pile of ones to be reviewed where they pushed the COVID vaccine up to the top. So he said what was sped along was all the red tape, but none of the safety precautions. And he also said that this vaccine trial had almost double the amount of volunteers, study members than other vaccines typically would. So he said, to reiterate, like you said, he said, you can be very sure that the vaccine has gone through all of the safety precautions that it should have gone through.
And the other thing that has also been sped up, Tommy, is normally when you develop a new vaccine, you develop it, you put it through its paces, it gets approved by the FDA, and then the process of manufacturing enough vaccine to distribute it to the community starts. Here, the process of manufacturing it was set up almost at the same time as the vaccine began showing promise. And that was a risk that the pharmaceutical companies took, because they might be getting geared up to produce a vaccine that didn't make it to the end. But that production system is there. And that's why you hear things like, well, we're going to have Pfizer says we're going to have 50 million doses available worldwide by the end of December. And the reason they're able to say that is because they already have the production system set up. They've entered into partnerships, and the Moderna did the same thing. Now, 50 million sounds like a lot. It is, but it's really a drop in the bucket compared to the world population that needs to get this vaccine of 6 or 7 billion, however how many we are.
A question was about testing, and it said, shouldn't everybody in the world just get tested? George, you want to jump on that one?
Yeah, you're the test guru.
Well, I would say that, the advice has been, no, not everybody needs to get tested. If you haven't been around somebody, if you haven't been exposed, you shouldn't need a test. And why is that? Well, I think it has a lot to do with there's not enough testing supplies to test every single person in the world quickly. Testing also requires PPE to get used up, gloves, masks. There's not enough to do everybody at one time or over a quick amount of time. So there are some hurdles to testing every single person in the world. Would it be nice to have your iPhone? You can, your iPhone just scans you and tells you if you've got COVID. Absolutely. I think everybody would say, do that. Everybody in the world do that right now. But unfortunately, we've got some restrictions for those testing methods.
And remember that the tests that you described, Tommy, are only good for one day. They only tell you where you are today. So even if everybody gets tested today, their situation may be different tomorrow with the types of tests that we're using to diagnose the infection.
Right. So I think everybody has always said, you know what, if there was an at-home test you could get for pennies, and you could test yourself every day during this pandemic, it'd be a no-brainer. Everybody could do it, but that's just not the reality that we live in right now. That test doesn't exist on a widespread scale. It's not cheap for those that are at-home tests, and it still has to be sent out to a lab to get run on. So, I think they just came out with a new at-home quick test that is out of the market. But again, for that to be widely spread and available to everybody is not in the foreseeable future. Great question. Great question. All right, let me say we did that one. Here's a question about the positivity rate in El Paso. And the question is, do we think that our higher rate of positivity is due in part to us living as a border town? How much of that do we think is relative to people crossing the border from Mexico because they don't have good health insurance or good infrastructure in Mexico, versus if El Paso was in the middle of Texas, would we be in the same predicament?
So I always wondered, Christy, do you have something to mention about that? Because I know you were looking into it.
Well, I'll take a stab at it. We've seen high positivity rates at different places throughout the United States and around the world. And I think it's a complex issue as why that's observed. Some of the speculation for what we're seeing in El Paso has been associated or suggested to be associated with maybe lack of access to healthcare. It's widespread. Multiple generations living in one household. That's very common here. And that's much more common here than it is in other places in the United States. I think that phenomenon of household transmission has a great role with that. And so some of the task force I'm have the honor to be part of, and from the different committees and the different folks working in our region and discussing those different aspects. Those are the things that have come up. But as we know, we have seen high positivity rates in other places, as I mentioned, and they go up and down. And I think we're still trying to figure out, what are all the different factors that are impacting those rates.
Thanks, Christy. Anybody else? Any comments? Here's a kind of a general question. And I remember when I was going through my residency program and took courses taught by Dr. Delclos, this history of disease was definitely one of them. And this question is, what should we have learned from the Spanish flu pandemic?
Oh, good, a history question. I love this. Well, the first thing we should learn from the Spanish flu pandemic, nobody ever knows, is it never started in Spain. Since I'm originally from Spain, I always have to make that point. It was called the Spanish flu because Spain was not was neutral in World War I, and all of the other countries in Europe and the US, which participated in World War I, had military censorship of the press. So it really wasn't a good idea to let the enemy know that you had millions of people with the flu. So Spain had their cases like everybody else, but they reported them because they were neutral. In reality, the Spanish flu probably started in a military base in Kansas and it was then spread to Europe after that. I think the main things we can learn from the Spanish flu, it was a natural experiment sort of that was done. There were a lot of the issues that we see today with coronavirus are not new. They also happened, resistance to masking being recommended and then people being resistant to masking or to avoiding large gatherings was also prevalent in the United States during the Spanish flu. And there was a very interesting natural experiment that was done between the cities of St. Louis and Philadelphia, in which one city, I believe it was St. Louis, was very strict about adhering to distancing between patients in hospitals and wearing masks, and Philadelphia did not. And you see when you compare the numbers of the flu cases in St. Louis, and I believe it St. Louis, it was St. Louis, the one that did it right, was very low, whereas they spiked at the same time in Philadelphia. And so that's very good evidence that the measures that we are implementing nowadays can be effective if people abide by them. So the main lesson is those measures worked then, they work now. And then the other lesson is there was resistance to these measures back then, and there's resistance to them now. And we have to be smarter about how to overcome that resistance to what we know works.
Thanks, George. A couple of questions were on the CDC and the days of recommended quarantine. And both of these questions said, why did the CDC change from 14 days down to 10 days? What should we be following?
Well, they haven't officially made that recommendation, I believe. I haven't checked in the last day or so, but I do know they're considering it. Mm-hmm. What they're doing is they do recognize that the 14-day quarantine really takes a toll on individuals, on businesses, when in reality, the majority of the time, the spread, if you're going to get sick from an exposure you had, almost all of the cases occur within the first 5 to 8 days that we were mentioning earlier, and they tail off. Some of them occur a little bit sooner. Some have been described as soon as 2 days after the onset, but that's unusual. It's really closer to like 4 days. And on the other end, yeah, you can get cases after day 8, but generally by about day 10, everything's done. So they're looking for ways to really help out society to try and enforce practices and kind of do a swap. So the idea is to shorten from 14 days down to 10 days, but what you do add is increased testing during that period of time so that you can detect it earlier, or so that you have several negatives in a row so that when you leave, and they're talking about 7 to 10 days. I don't know which side they're going to fall on. It may be 10 days earlier rather than 7, but you do more testing in that period of time. And if you're negative, then the likelihood that you have it is very low. Also, they are basing, the US is basing, the CDC is basing this decision also on the experience in Europe, where the quarantine time has not been 14 days for a while now. It was lowered to 10 several months ago. And And, you know, they're having their surge too, but there's not an indication that the surge is because that people didn't quarantine long enough. It really had to do more with the gatherings and the reopening.
All right, here's a couple of questions. Maybe Christy or Bob can answer some of these, and it's about cleaning your office space. We have our entire office cleaned professionally and sanitized every month. Would you recommend more often?
I'll take a stab at this. I can just tell you what we do here at the Health Science Center in Houston, that we have a daily cleaning regimen. It's not a deep cleaning, but it's a daily cleaning regimen. And then that's been augmented by a second visit during the day, focusing on the high touch surfaces, the handles, those sorts of things. But I would feel uncomfortable if you're just getting cleaned once a month. I don't know what the business occupancy is for something like that, but that seems too infrequent to me. I can't point to a study that says that, but Christy, would you agree with that?
Yes, I agree. And then keep in mind, sanitization refers to lowering the number of pathogens in the environment, and then disinfection activates them, rendering them non-infectious and not able to, cause infection and then subsequently illness in a host. So I think focusing, like Dr. Emery said, on the high touch surfaces, frequently touched places in office settings would be a more strategic approach. Maybe a deep cleaning that's a little bit more infrequent, probably more frequently though than once a month, but daily paying attention to those high touch surfaces like doorknobs and light switches and common areas and workplace settings.
And to augment that, whatever schedule it is that you set up, please remind the occupants, the employees, or the students, or whatever, they play a role in this, in that through their regular hand washing, keep your hands away from your eyes and your mouth, masking, the social distancing. So you can't just blindly rely on the housekeeping activity to be the entire solution. Everybody plays a part in this regard.
All right, thank you very much. Following up on that same topic is, how does one know the cleaning protocols that we should be doing? Is there a website they can go to? What resource do we have to give the attendees so they can know exactly what they're supposed to be doing? How often? Where's the in list? Does the CDC have a website they can jump to? Does anybody know it?
So I would recommend the EPA N-List, and you can just Google EPA N-List or N-List, and that website will pop up. As Bob mentioned, it's hard to say what the frequency should be, but the more number of people that come through, the more frequent the cleaning should be. And of course, the high touch surfaces need to be cleaned more often than that. And there's, with specific questions about surfaces, you can Google that, but make sure that you're going to these government websites, these reputable websites, rather than, asking a neighbor. Which is something that I've seen some crazy things, rumors out there, but EPA website, CDC website, World Health Organization website. These are all very good, reputable websites.
And if I may, don't get lured in by the vendor websites, because of some of these vendor products, they're making claims that I'm not sure if they've been substantiated. So I would certainly echo what Dr. Rios is saying, that go to these reputable sites and channel down through there to look for information that's objective rather than some of the vendor stuff.
Thank you very much. Dr. Rios, while we have you chatting with us, there was a question specifically towards you that asked about your thoughts on face shields. And let's take that in two parts. Is there a recommendation on face shields, and what is the recommendation versus facial coverings?
So wearing a facial covering is important. And I've been asked the question, well, can I wear a face shield instead, thinking that might be more comfortable? Face shields are hot. they're very hot. And I was at a store recently, and I saw somebody sweating through a face shield. She also happened to have a cloth face covering. So as I was checking out, she took off her face shield, or she pulled it up like this, and with her hand that had been touching my things going through, being checked out, she went like this. So that's defeating the purpose of a face shield. Now, I would recommend face shields for people who are working with unknown patients, or people who with unknown status of COVID, or for example, podiatrist, or I know a manicurist giving somebody a pedicure. So that person is below me. So if I'm getting a pedicure, the esthetician, she's down low. So she ought to be wearing something over her eyes so that she's not getting any of my secretions, we'll put them, especially at some salons where you can have a glass of wine while you're also getting a pedicure. Not that I go that often, but I do usually go on my birthday. So there are some people that I do think a face shield would be helpful, but they are not to be used in place of a facial covering or a mask. Let me say a mask. I hope that answers the question.
Yeah, I think it did. I think it gave some clarity. Thank you. A couple of questions were about antibodies and how long they last. And I'll let George jump in on that, but I guess I'll lead it off by saying I don't think we really know at this point. We know that there is some immunity, and whether or not you're going to get those antibodies is not guaranteed, and how long they last, I don't think is fully known. George, what do you think?
Right. So we do know that, and more studies are showing that antibody levels, or the presence of antibodies, depending on which test you use, there are variations on the test, last at least 5 months in most cases. However, there are questions. The first question is, we don't know if these antibodies mean that you are immune or not. For many diseases, checking antibody levels is the same thing as verifying that you are immune. We do that. We use antibody levels for measles, for mumps, for hepatitis B, but there are other aspects of immunity that don't involve antibodies that may be playing a role in coronavirus, and that aren't necessarily reflected by a positive antibody test. That's number one. Number two is, if there is immunity, we don't know how long it lasts. I think that anybody who has had a confirmed COVID infection is 100% immune to another infection for a while. We just don't know how long that while is. Most studies show that at a minimum, you're not going to get it in about 3 months. The documented cases of true reinfection, by reinfection, we mean you had COVID, let's say in March or April, you got over it, you tested negative, you went back to your normal life, and then lo and behold, in August, you have another exposure and you have another COVID infection. Those are very, very rare. There's only been about 4 or 5 reported in the world literature. And remember that we are now well over 60-something million cases. So it tells you it's unusual, although there are probably additional cases, but overall it's probably very rare. What does that tell me? That 9 months out, if reinfection is rare, that probably there is some lasting immunity. And certainly that's what's hoped for with the vaccines, that they can induce lasting immunity. We'll see. It may be that the vaccines offer several months of immunity, which would be great because that would be enough time to really control this pandemic. But we might need another booster in a year, just like we do for the flu. We don't know right now.
There were a couple of questions about, how long ago do we think COVID was circulating in the U.S.? I think there was an article today posted that said probably as far back as December of last year it was circulating. And one of the questions asked was, well, why did we not know it? And I'll tell you a personal story. We had a whole family, friends of ours that ended up in February all getting sick. Fever, cough. One of their youngest sons had to be in the ICU and intubated, double pneumonia. Nobody had a clue what this family had. They tested negative for everything. Well, guess what? They all have the COVID antibodies now. So that was February. And I think it's safe to say that by all accounts, it looks like it was even here well before then. Anybody have any updated information on that? All right, looks like we're down to our last minute or so. So again, this entire webinar is going to be recorded and sent out to everybody. We are not going to get to all of the questions because you guys typed in great questions and plenty of them. So what we will do is we will get together with the chamber and make sure that we have typed out the answers to these questions so that everybody has them, because we want to make sure this information is passed out to everybody. Let's see, let me just find a quick one here. Testing, we hear a lot about false positives. How and why does that happen? What can someone do to ensure they are truly negative or truly positive? You know, no test is ever 100% flawless. Even the PCR can come back with a false negative or false positive. So you can never be 100% sure, but what you can try to do is make sure you're getting the best test out there. The best test out there is a PCR test. There are other tests out there. There's oral fluid swab tests that are out there. They're good tests too. The antigen quick tests are good tests too. But if you want to be as sure as you can't go wrong with a PCR test. Yes, there are false positives. Yes, there are false negatives, but the PCR is as close to perfect as you can get. So if you want to make sure you're limiting those chances of false negative or false positive, you can't go wrong with a PCR test.
The other thing you can do to improve the percent positive is repeat the test, which we don't do very often. But if, let's say, you know, one of the things that you can also do to decrease, before I forget that, the false negative, false positives, make sure you test at the right time. If you test the day after you're exposed, I can bet you almost 100% of the time it's going to be negative, and it may well be a false negative because, as we said before, it takes several days before you actually develop the infection, like day 5. So if you test on day 3 and you get a negative, that should not provide any reassurance to you. You need to test later during the window, the day 5 through 8. And if you question anything, you retest and you retest. We've had several cases in the hospital that came in negative, because they test everybody nowadays in the hospital. They tested negative, and then the next day positive, and they were in the hospital. It was just a matter of hitting that window. So repeating it will increase the accuracy. Probably accuracy is the better term instead of the false positive, false negative, but the accuracy of the test.
Excellent. And also, you know, I think we've learned too, it also depends on the skill of the swabber too. As you know, are they following the directions set by that lab or that manufacturer? If it says deep posterior, you know, nasopharynx swab, it's and they just do the outside of your nostril, you know, you may get a false negative or false positive in that regard too. So just make sure, you know, wherever you're getting your test done, you can be confident that they're administering that test accurately as much as you can. So with that, I think we're going to close up shop. We've been on here an hour and a half, so we appreciate everybody's time. And again, we're going to get all this information out to everybody, answer everybody's questions. So we again thank the chamber for allowing us to be a part of this webinar. We hope it brought you some good information. And I'm going to stop talking and pass it back over to the chamber if they have any closing comments.
Sure. No, thank you, Dr. Heisler. And on behalf of the Hispanic Chamber, thank you to all of our panelists for sharing your expertise, your knowledge with our community. And thank you so much. And like Dr. Heisler said and mentioned earlier, we will provide all of the answers through a separate email and follow up with some additional resources. So thank you again. Thank you to our viewers. Thank you to our panelists, and have a Merry Christmas. Have a Merry Christmas. Thank you.